You are the Canadian Donation and Transplantation Research Program. You are CDTRP.
The CDTRP is a network of more than 400 clinicians, senior, mid, and early career researchers, trainees, patient, family, and donor partners, and 100 partner organizations. Our network has supported 275 collaborative research projects and has mobilized research into policy change, legislation, commercial products, and improved knowledge for patients, families, and donors. Every year, CDTRP supports between $30 to $40 million in grant applications, something around 60 to 70 individual applications. You are CDTRP. These achievements wouldn't be possible without your hard work.
CDTRP Research Services is a platform that supports principal investigators to develop high-quality research in donation and transplantation. We work hand-in-hand with CDTRP investigators to maximize the effectiveness of research teams through support with funding development, project management, patient, family, and donor partnership, knowledge mobilization, events, and trainee support. Across the 5 research themes, we help teams mobilize new knowledge to ensure patient, family, donors, healthcare systems, partners, and stakeholders equitably benefit from research results.
If you are a basic scientist and would like support with your knowledge mobilization plan, if you are a busy clinician scientist with limited time for research but would like to run a multi-site study, if you are an early career researcher and looking for collaborators to help with your grant applications, if you value patient, family, and donor engagement but are not sure how to find the right patient partners or what role they will have in your project, if you don't have full-time research staff but need support,
we are here to help. Our experienced management team can support you at every stage of your research in donation and transplantation.
Now you are probably thinking, how can I request CDTRP Research Services support? The answer is simple. Go to the CDTRP Research Services Platform website, fill out the form to request support, and we will get in touch with you to discuss your needs. That's it.
We.
Nous.
Noi.
Nos.
Emis.
Nosotros.
Menk.
Kiano. We. Kiano.
Our CDTRP, and we will drive research advances so that every wish to donate is fulfilled and transplantation becomes a lasting and sustainable cure.
You are CDTRP.
Email us today.
Welcome back, everyone. I hope you had a wonderful break. My name is Geeta Sanmagalingam, and I work as a CDTRP research manager. The main study I work on is Treat COVID, as many of you know, which is a cross-country questionnaire study enrolling transplant recipients from both the solid organ transplant group as well as bone marrow transplant recipients and caregivers to understand the continuous impact of COVID-19. Today, we're going to be looking at Treat COVID progress as well as the plan ahead. I'm going to go ahead and share my presentation. Okay, hopefully you can see my presentation on full screen. So thank you for joining us virtually for the National COVID-19 session. And then I already introduced myself. Today we're going to be hearing about Treat COVID and how the PFD have continuously contributed so that we have a multi-provincial, multi-site pediatric and adult solid organ transplant and bone marrow transplant and caregiver family member questionnaire study. Transplant patients are among the most vulnerable to severe outcomes from COVID. That was true at the beginning of the pandemic, and that remains true today. Immunocompromised people now represent about 25% of all COVID-related hospitalizations, and despite being a relatively small population, both hospitalization.
Geetha, we're just gonna stop you. None of us can see your slides. I'm sorry.
Oh, okay. Sorry. Is that better?
Yes, thank you.
Okay, sorry about that. Just gonna. So both hospitalization mortality rates today are higher for transplant recipients than the rates for general population at the beginning of the pandemic before vaccines, when these rates were considered an international emergency. So I wanted to share some of our disclosures and thank our funding partners. So these are all our shared study funding funders: Health Canada, AstraZeneca, University Hospital Foundation, and FRQS. Transplant Research Foundation of British Columbia, and CIHR, and there are no other relevant conflicts. Today's forum agenda, I've broken it down by the amount of time that I'm going to spend on each section, just so that people from different time zones have a good understanding of that. So here on our agenda for the next 90 minutes, we will have a presentation, a rich and engaging PFD conversation, and a dynamic breakout session where questions will be presented and the audience is encouraged to ask questions, tell their stories and experiences of COVID and other infectious diseases. Our speakers today will be Dr. Dima Kabani, Rank DeVries, Sherry Logan, and Lindsay Thompson. Dr. Dima Kabani is an assistant professor in the Division of Infectious Diseases at the University of Alberta, where she leads education for the Transplant Infectious Disease Fellowship Program. Her clinical and research focus includes infections in immunocompromised patients, particularly in organ transplant recipients, and responses to COVID-19 vaccines. Sherry Logan is a caregiver of a pediatric liver transplant recipient. She has over 15 years of experience improving transplant health outcomes through philanthropy, patient advocacy, peer engagement, and research. In June 2024, she earned her Master's of Public Health with a specialization in health promotion. Sherry recently joined CDTRP as a communication strategist consultant for Treat COVID project. Rank DeVries lives in Oakville, Ontario, and runs a consulting firm that has provided services in the water industry for more than 15 years in Canada, the US, and the Caribbean. Rank has been a patient researcher and a patient family donor, PFD representative, on the CDTRP Theme 5, Restoring Long-Term Health. He had a heart transplant in December of 2012 and has been involved in a number of transplantation-related research projects over the past 10 years. And after 35 years in the healthcare field and a surviving acute myelogenous leukemia with chemotherapy, radiation, and a bone marrow transplant, Lindsay Thompson now actively volunteers in patient education and advocacy. As a PFD co-lead and partner at CDTRP, she uses her experience to support research and professional education and healthcare improvement. So those some great achievements there, and I want to welcome all of our PFD members. And I'll move on to some of the objectives that surround Treat COVID. And I'm sure a lot of you have a familiarity, but just as a reminder, these are the three objectives for the Treat COVID study. So transplant patients were systematically excluded from all of the large clinical trials on approved vaccines and therapeutics. So since vaccines became available, we have been co-designing research with stakeholders, including patients and families, to fill these gaps. With funding from Health Canada and other partners to address emerging issues, we launched the Treat COVID project in 2023. Through the engagement process, we were able to look at three lenses. The first lens was the clinical perspective. It looked at things like age, sex, gender, or it continues to look at those, as well as mental health, because that was an important component through that we learned through one of our PFD forums. And the last but not the least was the economic perspective. We're looking at the economic burden of COVID on transplant recipients and their families, and the value of different therapies which may differ from the general population. With the goal of over 5,000 transplant participants and their caregivers and family members are being asked to enroll to answer questionnaires online about the three objectives. Questionnaires are sent every 3 months online over 2 years. We want to hear your voice. Solid organ, bone marrow transplant recipients and their caregivers and family members who do not need to live together can enroll. Once the first set of questionnaires are complete, each participant receives a $15 gift card through their transplant center. And of course, all COVID vaccine statuses are welcome to enroll. This is a slide of our brief roadmap that was co-created with the PFD community. This was long before I joined CDTRP, so I don't want to go through each of the forums, but from our last forum, which was the 5th opportunity that we were able to talk about Treat COVID, we were able to understand from our PFD members that there was a need for evidence-based, practical, and targeted knowledge translation strategies. And my next slide is going to explain that a little bit more. The ASM in December 2024 asked the following breakout questions of our PFD members. What are some conversations that you're having with your family and healthcare team about COVID and other viruses like the flu? And what are barriers that there are to talking about research and COVID with your family member and caregiver? And what can make this conversation easier? And some insightful responses emerged. And I'm not going to read all of them, but the underlying theme was that there was a need for improved knowledge translation strategies to ensure the transplant recipients and their families receive clear, evidence-based, and transplant-specific information on prevention and treatment options. This now fed us into our current PFD forum. But before we go out to our current PFD forum, and just a Treat COVID update, we have 11 enrollment sites in BC, Alberta, Ontario, and Quebec, and all of them are officially open. Some of them are allowing self-enrollment, so I'll talk a little bit about that as well. And you can sign up for qualitative interviews and focus group discussions that will be taking place virtually through the University of Manitoba. So that was a major milestone that we were able to reach this past spring. We have 700 transplant recipients that have enrolled, and you can see the breakdown of numbers. And this is what it looks like in terms of our progress towards our goal of 2,590. Okay, so we're at 27%. And then family members and caregivers were a lot less. We're at 164. So the hope is to have a one-to-one pairing of a transplant recipient to a caregiver family member. And we are hoping that there are going to be some strategies that we can come up with that will help with that. So we're at 6% towards our goal. And I want to share the most important part of this slideshow, which is self-enrollment is open at most of the sites, and you are welcome to share this data platform link. Marie-Claire is just going to put in the bit.ly link in the chat. So you can use your mobile phone to scan this QR code, and that will take you to this data platform. It talks a little bit more about the study, and you're also have the ability to go to the Enroll Now button. That will take you to the eligibility questionnaire. And if you are eligible, you will have the consent form for the transplant center that you're associated with come up. You can sign up on there. And once you sign up and you're agreeable to that consent form, you will have a study ID number that is associated with you. It's really important to write that study ID number down because that's what you're going to hand over to your caregiver and family member so that they can sign themselves up as well. This allows us to track which caregiver is associated with which transplant recipient. And if you're interested in speaking to a research coordinator at your transplant center, click on the contact tab right here, and you will have their contact information available to you, which is their phone number as well as their email address. Today's breakout session is going to include these two questions. So our topic is making informed decisions on COVID and other infectious diseases. The first question is, what do you need? What kind of information, tools, or data to make informed decisions? And our PFD panel has kindly is going to ruminate a little bit about that. And number two is, what are the barriers to access reliable, valid, and current information? So I want to thank the presenters, Dima Rink and Sherry and Lindsay. And then once we are done with the PFD conversation, to ensure equal distribution in the breakout session, we'll randomly assign you. So you'll pop out of your main Zoom window into a breakout session room where there'll be a facilitator and a note taker. And hopefully you can all do a round of introductions. And a point also, a PFD member is encouraged to present the discussion when you come back to the main Zoom. So please raise your hand if you're interested in presenting. I want to thank the national team, so everyone on this slide, and specifically Rink and Sherry for being our co-leads, and Lindsay for joining us on this PFD panel. And of course, please do enroll and share share this QR code as well as the bit.ly link within your social network, on social media if you feel comfortable. If you have any questions that I can answer, please do email at info@cdtrp.ca, as well as my personal email here. So please welcome Dr. Kabani to share Treat COVID progress and plan ahead. Welcome.
Thank you, Geetha, and good afternoon, everyone. Okay, I'm just going to share my screen. Can someone please confirm that we're good with screen sharing? Can you see my slides?
Yes, we can.
Okay, perfect. Good afternoon, everyone. So what I'm going to try to do in the coming 10 to 15 minutes is give you a progress on the Treat COVID and what do we still need to do. I'm the lead on the clinical part, so if you're here to listen to the mental health and to the economic update, I'm sorry I do not have those information to share with you, but we'll have some more of the information when this part of the data is analyzed. So before I jump into the Treat COVID, I just to give you a background on why we decided to do the Treat COVID. So this is just from a Japanese registry looking at solid organ transplant and at the general population. And as you well know, this is no news to anyone, is that as we moved from the first waves to the Omicron waves and the virus has changed, more vaccination and treatment, there was decreased mortality both for the general population and our solid organ transplant recipient. But as you can see in the dark orange is that the mortality remains higher in this solid organ transplant compared to the general population. But if we zoom in to just the transplant population and to some Canadian data on our transplant. So this is a longitudinal study, which means they were able to get all the PCR from the solid organ transplant patient at UHN in Toronto, and they had 1,975 cases, so a quite large number. And they just showed us what happened with our solid organ transplant with COVID. And as you can see in green, as the number of vaccination, early treatment, but also the change of the virus from the Alpha Delta to the Omicron, luckily we had less hospitalization, less oxygen need, and less deaths. And this is what we continue to see with the different subvariant with the Omicron. So what we know so far, and this is from the pandemic, and we continue to get info post-pandemic, is that the strains that we're seeing are less pathogenic, which means is that they're causing less severe disease, and that's in the general population and in our immunocompromised individual, including our bone marrow transplant and our solid organ transplant. Um, you know that COVID-19 strains will continue to change. If you're up to date on the news, you might have heard of the newest name of the variant that's called Nimbus. If you're not up to date, that's okay. I had to Google the name of it a minute before I I joined this meeting. I cannot keep up to date with the newest names, and I do not think that the name is important, but the good news is we're not seeing increased severity of the disease. What we know is that vaccines are available and they're recommended by the Canadian Immunization Task and other advisory committee worldwide. The good thing is that the antivirals that are available continue to be active against the newer strain. One caveat is testing is less available. So the reason when we started thinking about the study is one, what Geetha mentioned is our solid organ transplant were really not included in any of those randomized study. Most of the data stopped with the pandemic, and there is still a lot of anxiety from our transplant patient about what's going to happen now. And this is why the idea of the Treat COVID started to look at not just clinical, but also economic and mental health. So Geetha started by showing you some enrollment number. This is what I'm showing you is what we analyzed 2 weeks ago. So just so you can get a taste of what information we have. We had 842 enrolled. I did not analyze any of the pediatric data and anyone that had the a lot of incomplete data because that will not give us accurate information. So we ended up analyzing 638 participants, 527 of them are solid organ transplant, and the rest are family members or caregiver. So I can tell you my phone beeps every time a person enroll. And since I've started this talk, we had 3 people enroll in the study. So that's good news. And if we look at the participation from different provinces, Quebec and Alberta started before because we had problems with getting contract, with getting ethics in the different provinces. And so you see the larger numbers we're going to get results are from Alberta and from Quebec. So if we look at the demographic of the transplant and the caregivers that are already enrolled, the median age is 59 and 56 for the caregiver. Half of them are male sex, and the caregiver, the majority are female. The race mainly are white North American, but it's nice that we have contribution and participation from others. So we're trying to capture as many groups and whoever is interested to participate in the study. And then when we looked at their job status, 1/3 were retired, 1/3 had the full-time employment, and a few had part-time or were on disability. When we look at the solid organ transplant, the group distribution of the different organ that participated in the study. You can see the majority are kidney, but not by much, although kidney transplant is usually the most common organ that gets transplanted. So we have the largest number, but we have 24% liver, 25% lungs, and 8% heart, and some of the combined transplant and kidney and pancreas transplant included also in our cohort. What we know is that most of the solid organ transplant that have participated are not early in their transplant, but a bit later. So the median is 6 years from transplant. 10% have had a previous transplant or have required a retransplant. 2% had had rejection before they participated, and their immunosuppression is, if you're a transplant, you'd be familiar with those names, and these are the most common immunosuppression that are used in our transplant. Now, if we look at some of the data about vaccine, and this is what we were going to look at, how many SOT and caregiver are still getting vaccinated, and if those vaccines actually affect how if you get infected with SARS-CoV-2, your outcome. And so we can see that more than 90% of our solid organ transplant have received at least 2 doses of COVID vaccine. But when we look at 2025, so last year, we've asked the participant, how many of you have actually had a recent booster? And you can see that still more than half have received their COVID-19 vaccine. If you look at the general population, that's actually a very good number from for transplant. But we have a lot of unknown. So I do not know if those unknown have answered that question, if it will drive this data more into not received or increase the received more. So when we collect data, if the unknown are large, then we run into the problems when we do analysis. When we look at the caregiver, again, only 5% have never really received any COVID-19 vaccine. The majority have received a COVID vaccine. And then when we look at the 2025, so last fall season, again, comparable to our SOT, their caregiver, 50% did get a 24-25 booster. And again, the number of unknown is still high. So I do not know those 32% if they're going to be in this area or that category. This is just to show you, because I'm interested in vaccine, and when there's a new vaccine, if our transplant when there is not enough data in our transplant population about these vaccines, if they are interested in taking them, especially that the RSV vaccine is not a publicly funded, and you can see compared, for example, to the flu that's publicly funded and that's been there, less transplant have received the RSV in the past 2 years since it's been out. So what about COVID? So one of the main reason we are going to look is how much COVID was there, and there is still. So on one of the questionnaire initially, we would ask people, have you ever had COVID-19, and if so, how many times? So 64% have had COVID. The ones that have said no, some of them might have had it but have not tested, so there is really no way to know. This is all by asking if you think you've had COVID or you've had testing that has come back positive. And similar to the general population, our transplant have had at least 30% have had more than one episode of COVID over the past year since SARS-CoV-2 started circulating. And same as the caregiver, 60% answered that yes, they've had infection prior to enrollment. Now, when the main study objective was not to ask questions and see if you've had COVID in the past, but now if you've had COVID, how are you doing? So, and what we're trying to do is ask them if you've had any other respiratory virus, and this is likely would be captured if you've gone to a hospital or if you your transplant physicians have tested you. And at the University of Alberta, we're providing our transplant with a respiratory swab. And so if we look at COVID, since this is the main question here in the study, so since enrollment, so we started enrollment at the University of Alberta. Maybe the last fall. So 10 out of the 200 patients that we've had the one episode of COVID since they've enrolled. There was one hospitalization, and when you look at the detail, usually when we worry about COVID is like the breathing gets worse, and actually the hospitalization was just because of hydration and diarrhea rather than issues with breathing, and was discharged a few days later. And 7 actually were offered therapy and were treated with remdesivir. So our transplant, the good thing is they're still getting treatment. So, um, so this is the data that we have so far from the clinical. Because the number of COVID are too small, I cannot do any further analysis to say who are likely to get COVID, who are likely to get vaccinated. But hopefully, with more numbers, we can give you some more information. We had a lot of problems in starting the study and starting enrollment. I know you've heard us over the past 2 years about the study, but finally all the sites are open, so hopefully we'll see an increase in enrollment. The data that we have about COVID-19 so far is retrospective. That means people remember if they've had it or not, rather than people since they've enrolled in the study having a positive test. We're going to work on those missing data. People are busy, so they don't have time to fill all these questionnaires, and we've heard that vaccine data are not easy to get in different provinces. And even when we get the information, the final information, which is hopefully with a much larger cohort, might not represent all of the transplant patient in Canada, since to participate in the study, you need to be willing to participate and follow and fill information, and not everybody is interested in research. The big thing is we need you here to help us enroll. So if you know a friend or a place where you can uh, tell transplant patients in any province about the study that this is ongoing if they'd like to enroll. So having more patients will help us get more information about what COVID is doing and compared to other viruses, and hopefully we'll give you some more information about mental health and economic health. Geeth has already shown you this, and thank you for listening. So our next section would be with Rain DeVries, Sherry Logan, and Lindsay Thompson. So I'm gonna stop sharing.
It's all you, Keitha.
Welcome, welcome. So I don't have too much to say. I just want to say thank you so much for joining. And we're just going to talk a little bit about what are some of the conversations that are taking place within families and households with transplant recipients. And maybe you can give us some context about how you make informed decisions based off of the information that is available.
All right, any of us can start? I'll start. First, it's great to see a lot of familiar faces in the crowd. So it's nice to see everybody back here because I think it's an important thing to keep talking about, as Dima mentioned. But like from the beginning, it's sort of changed. You know, one of the frustrations we've had for those of you that have been involved in this for a little while now is trying to figure out, you know, where do we get useful, accurate, sort of repeatable information that's relevant to immunocompromised individuals or people with solid organ transplants, because the stuff that's out there wasn't really that useful. And so it causes, I know most of us, a bunch of stress along the way. And so, whenever we look for information, I guess personally, it always starts with people that I would trust, and I think we all have figured that out. Um, so if I had an issue with any kind of respiratory thing or virus, I'd probably go to Coleman Rothstein at Toronto General, because I know he's good. I trust him. He has normal conversations, treats me like a human being, and so he would answer my questions, just give me information, help me make decisions. So it's individuals. Same thing. I get a lot of skin cancer as kind of a byproduct of taking the various medications. And so I'd go to Dr. Chan. Why? Why I get involved in his studies. I kind of know what he's up to. I really appreciate the time and effort he puts in, and he treats me like a human being. And so you find all these people in your network that you trust. And now, like if I had a question, I would call Dr. Kobani, because I trust her, because we've been sort of in this community and this network, and we're all trying to solve these problems, right? So there's individuals that I would get information from whenever I had a clinic visit or whenever something was going on. So that's one thing. The other thing, of course, we all look for information, and I was going to say I'm kind of old school. I would look at the New England Journal of Medicine, look at research, look at you know things like PubMed. My wife subscribed to PubMed whenever something kind of comes up that's in this area that might be of concern. And she'll pull that information down, print it out, we go through it. And so we have our own little sort of research team. And then of course we're all subject to stuff in the newspapers, in whatever sources we get from friends and everywhere else, sort of the general public type stuff. And I think it's still relevant because we're living in a society that may or may not care or focus on our particular plight. There's a lot of bigger things going on in society. So somewhere we need to know that, so that we we know the context in which we're making decisions. Like, the government says you can't travel anymore unless you do this. Okay, all right, So these are all sources that are really important. And then finally, I got to give a quick shout out to my wife. She's a caregiver in this situation. She's not on the call now, otherwise, she still wouldn't say anything anyway. But she is great at research, and what we take all this information and we kind of on an ongoing basis try to make decisions based on the best information we have. In the beginning of COVID, there was not not good information. It's sort of like, hey, let's see what happens in England, see how many people die. Maybe we should not do what they do if a whole bunch of people die. It was very, very high level. And so as more information came available, we're able to do that a little bit better. But still a lot was always based on the general population. So we're trying to figure out, okay, how much do I trust my body? I understand my body. What do I think I can take? What action can I take? And then what information keeps coming available. So that's, I guess, just to kick it off, that's how I sort of did it, but everybody did it differently, right? And I know Sherry, Lindsay, you had, your experience were similar yet different.
Yeah. No, thank you, Rank, for kicking this off. I think that you brought up some really great points. Um, I think one thing is most important to identify is that on this transplant journey, so just to give you background, I'm a caregiver of a liver transplant recipient, but along this journey, there's a lot of uncertainty in even without any kind of infection of COVID, the COVID pandemic swooping in. So, in itself, the journey, there is a lot of uncertainty. When we add layers of additional uncertainty in it, it can become a lot more anxiety provoking, can increase PTSD and all of those pieces. So just wanted to mention that because I think the uncertainty is something that we live with. It's just we've had heightened uncertainty due to extra elements added in. I also go to trusted sources, as Rink mentioned. For my trusted sources, my first and foremost go-to is our transplant center, and inviting those conversations and asking specific questions. A lot of the time, there's still unknowns as far as new variants and how effective, the vaccine will still be. And a lot of it is like, as as the variants come, the vaccines are changing with them to be effective. So usually the response is that every family is doing what they're most comfortable doing. It's not always the easiest to interpret what that actually means. So, because there's again so much uncertainty in the response at times. Another place that, I feel like has been a nice strategy from the beginning has been a transplant peer support group. It was actually started at the beginning of COVID, and it has been incredible to continue. And we're meeting now every other week rather than every week. But within that group, there are transplant recipients, caregivers, and experts in transplantation that as we share information and learn from each other, we also support each other. So it's a great opportunity to learn from each other, what's being done. And it is across Canada, so you learn different politics across Canada as well, and what other places are using. As well, our family doctor is a part of the discussion because, we're not just a transplant recipient, we are to caregivers and a sibling of the transplant recipient as well. So we need to understand, individual risk as well as we're making these decisions. Um, there is in Ontario a public health website that gives it's an Ontario respiratory virus tool that gives it's a good dashboard of indicating the trends of not only COVID but RSV and influenza as well at any given point. And it's broken down into different categories of like projections, trends, different public health units, and influenza strains. And it does all sorts of measurements as well across those different categories. And then another one that I've used is COVID-19 Resources Canada. So again, this one's a national tool that tracks COVID-19 hazard index. So the Moriarty Lab, I believe, is the one that actually creates and generates the data, takes a look at risk factors, excess mortality, and is really Canadian COVID data that it's focused on. And I guess the last piece, well, being involved in the Treat COVID study, again, another trusted source. So I get access to the information as soon as possible, and really promote that, making sure that that information is being transferred to the community as much as possible so everybody has access. And then finally is like the exposure risk. So that's another piece of it. What are our environments that we're living in? And so this spring might be a different environment because we're outdoors and living outdoors. Whereas the fall, as my daughter, who's a transplant recipient, she's at Western, so goes into very large classrooms, and that risk exposure is much higher. Makes a difference as far as like what we choose to do. I'll leave it at that and change it to Lindsay.
Lindsay's trying to think because you both have stolen quite a bit of my thunder. I think one of the things I want to bring up is just like with the falling numbers in immunization, the whole rush of COVID has passed, and people aren't so committed to maintaining their vaccines. And when it's fall like respiratory season, or I was a pediatric nurse, we called it cootie season. When the schools went back, everybody mingled. And I choose to wear a mask when I'm out or go shopping. And you get the looks from people. And why are you wearing a mask? What's wrong with you? It's part of the information we need to get out to the general public is there are still immunocompromised people in the world, in your town, still dealing with the effects and consequences of potential COVID disease, and continue to push the need for vaccines.
No, that's very true.
And I think like the thought, I don't know if Lindsay, you want to go first on this because we seem to have,
Yeah.
we'll go backwards. How about that? Give Rank
Well,
a little
well,
bit
as
to
for the
sweat
next
about.
one, leave the wastewater to me. I mean, this is my baby, so you can cover
Now
all the
that
rest.
was an Alberta project.
Well, no, that surveillance has gone all over the place, the US and
I know. I
yeah, I
know.
know. So
It's
I'd love to
remarkable.
talk about that. But
So what was the
So
next
Lindsay, do you want to
question?
talk about the measures? You want to talk
mhm.
about the measures you used in the past or currently use to understand the relative risks in your province, city, or yourself and for your family?
Mhm.
I'm a news fiend. I'm old school like Rank. I watch the news every night, and so it's you're trying to get a sense of what's going on locally because that's what's going to impact you. And then looking at what is going on across the country just for general information. But I'm sorry, my brain is shutting down. I apologize. Um, it also helps knowing the local information. It also helps to deal with the local responses and and then trying to be aware of the local miscommunication that's going on out there locally and nationally that gets has a field day on social media. I think that's a big problem that we immunocompromised people need to deal with because there are the anti-vaxxers, there are immunocompromised people that refuse to get vaccinated. And I think a big part of that was, as we discussed in the past, was the whole COVID process. Instead of being a health issue, became politicized. And the politicians took over. And I'm sorry, politicians are not public health people. You know, it's you look at Bonnie Henry in BC, was did a fabulous job. She got a provincial award for it, where Dina, her name is gone, sorry, here in Alberta, was fired. And they made it, the government made it impossible to find another job. And that took over the whole health aspect of COVID.
Yeah, when that becomes the headline, right? That's not what they should be focusing on. They should be focusing on the issues people are dealing with. No, it's true.
Yeah.
Yeah.
But
So maybe I'll
to
go
the
next.
no, I was just going to say, but to what we're talking about, it's how do we get more people involved in this study and across the country? Because obviously Alberta started sooner. They got bigger numbers, but I understand like the enrollment in Chum in Montreal, which was the second site, is very low. So I'd be looking for suggestions from the full group here as to how we can get these numbers enrolled, because this is an ongoing project
Mhm.
and we're getting stymied.
Yeah, no, it's true. And one of the things, one of the reasons we wanted to have this forum is to, to make sure that we get enough information so we can answer that question of where do you get your accurate data? Well, if we can get the research in place and we can't enroll enough people, then for us, we have to go back to those original sources that we're looking at now in terms of, hey, where did you get your information? That's one of the things we've been trying to address for a while now. And we're getting to that stage now where we are getting enrollment, we're getting some data, but we just need more to be able to answer those questions better. So that like Sherry was saying, is we as CDTRP become that source of truth or information, or support the production of information we can really trust. Because I know the question we're trying to answer is trying to figure out, okay, where are your sources? And I know for me, and the reason I saw that wastewater one in there was because I've been in wastewater for about 40 years now, and so we put a team together to do wastewater surveillance. And people, even in the general public, don't understand how much power that has in terms of impacting healthcare before the problems become a pandemic. So, and so I always go to the wastewater, and this is a shout out to Sean. I checked the last time at Gold Bar, the wastewater plant in Edmonton. So the viral load right now is very low. So you should be happy. I checked the facilities in Toronto. Those of you that live in Toronto, the Ashbridges Bay, it's low. For the Humber and one of the other plants, Highland Creek plant, it's actually high. So two of the four places across Canada right now have a high COVID viral load going in. And what I really liked about that source, partly because I'm in it anyway, is because it's more proactive rather than reactive. By the time you hit mortality statistics, gee gosh, we're a bit late. So we need to be looking at things that we move forward in terms of anticipating when these problems are going to happen. Now, are people aware of those? So the federal government has a dashboard which is talking about viral loads and other kinds of loads. They can do that. They can analyze that wastewater for all kinds of things. The only thing we used to use it for is to check drug-related problems. Where were we having problems with certain types of drugs across the country? There are more cocaine in Toronto than we do in Calgary. But there are many healthcare-related things that we can do to have information up front before these pandemics bite. Because if I know that in a particular area, community, neighborhood, whatever, that viral load is going up, well, maybe I wear a mask to go to the store because I know there are a bunch of people out there that are already infected. They may show nothing, right? But they're already carrying because it shows in the wastewater. So I think for me, that was always a really big deal. What I also know is that they're dismantling all of that right now. And so, because I know I do consulting for one client, the Ontario Clean
Right.
Water Agency,
I
and
was just,
five
I,
people had to bring into the organization because they're no longer doing the wastewater surveillance. So anyway, Sherry?
I was sorry, I was just going to jump in, Rank. I agree with you. Like, we're trying to bring this under the umbrella of CDTRP, but the big challenge is if we gather this information and we make it accessible through the patient portal, we need to make sure there's a mechanism to keep it current.
Yeah.
So that then becomes a responsibility of CDTRP to make sure that the latest, greatest is available on on the patient portal. And that may be a challenge.
That's great insight, Lindsay. And I don't want to be the timekeeper, but I do want to make sure that we get into our breakout rooms in a few minutes. But are there any questions from the audience that we can take? Just sort of scanning the chat box. It looks like, can we attend the transplant events and fundraisers? Or at least sign up with the QR code. Yes, Donna, you can sign up. I think you're asking about the study. You can sign up through the QR code.
No, I was meaning, can we not take a poster, like even just a letter size with the poster printed out with the treat COVID and the QR scan code to take it when we're at a picnic or something, pass it around. You might have a shot at getting a pair to sign up instead of just one.
That's a great idea. If that is within your wheelhouse of resources and you have time to prepare, we can prepare like an infographic that I can send to you. We have graphics available. And I can definitely, and I think Patricia is concurring that we have postcards that we can also send to you. So if you have any local transplant events that are happening within your community, please do reach out to us. We have the resources and we can get you postcards, any information on tree code that will help.
June 22nd is what I need it for.
Okay, great. Donna, I'll get in touch with you. Any sort of concluding remarks? I know we want to go into the breakout sessions next, so that was a great PFD conversation, by the way. Thank you, Sherry, Rank, and Lindsay. I will now ask MC Marie Claire if you can randomize everyone, and we'll see you in either breakout room 1 or breakout room number 2. Hello, everyone. Thank you for coming back to the main room. So I hope you had a very rich and engaging conversation within your breakout sessions. Can I call upon breakout room 1 and ask who your representative is and if they can start the notes?
Sure, I think we are group 1. Rink was our facilitator, and I will be the presenter. We had a great discussion, awesome group conversation. And speaking about the question, what do you need to make informed decisions? We talked a lot about statistics and percentages, information that shows how important and the differences are in terms of using numbers and graphics and using plain language, using lay summaries that will bring the numbers, the results, and the accessible words that will explain to all the people the relationship with vaccines and health. We also talked about developing target information for patients, for families, friends, and caregivers, because not only patients need the protection, but also people around. So then we can improve the protection around people with immunosuppressed people. And also we talked about some comparison between the general population and immunosuppressed people. What is the difference in terms of health outcomes comparing those two groups of people? Because that can also bring the relevance of being treated or not. And yeah, so this is, am I missing anything, Rink? Or
No,
the
just,
other?
I know Manuel had that question about, the data that we have so far from Alberta, that, does it look like there's some hesitancy? Why is that? So the data, we want to see some data, but then we may have to dig into it a little bit more too. I think, although it's just the beginning of some initial data, but, we should be looking out for that also.
Yeah, and we also talked about looking on the other side of the picture, like what are the effects on the vaccine, if there are any side effects for recipients, and what they would be to help the recipients to make a decision and to feel comfortable with potential side effects.
Yep.
Those were kind of the highlights for our question number 1. Should we pause here and wait for the group 2?
Yes, thank you so much, Mano and team. That was it sounds like you guys had a great discussion. I'm going to call upon Christy to chat a little bit about what we spoke in breakout 2.
Alrighty, perfect. Thank you, Geeta, for sharing the notes with me, because our group was very chatty. So we covered a wide range of topics within this topic. So when it pertains to the information data or tools, it was discussed around the need to really have access to accurate and transparent information, both on a local as well as national stage, understanding, of course, that The delivery of healthcare is a provincial issue, and that can, of course, cause some impediments to the ease of access of information. But how a lot of the time the onus really does rest on the individual to seek out that information. So how we can go to our transplant teams, how we can look at more of that sort of macro system information, whether it's more the wastewater collection, the current vaccine, as well as I guess infection sort of surveillance data that may be available in some provinces, but not necessarily all provinces, and really how we continue as recipients, but also as families, to want access to current information that not only addresses those really pertinent pieces related to what is the current vaccine status, the information or current vaccine access, the strains, also the prevalency of the infections, but also around just understanding the social emotional aspect that the viruses, of course, particularly COVID, can have on the total family system, and how really family doctors are also a direct source of that information, because for many recipients, they are the ones that we have the most direct relationships with, and who we see on a more regular basis. I think that's, and then of course we branched out a little bit more into the current climate as well, and how that can impede the access to some of the information, and how now with the prevalency of the measles and some of those current conditions around, I think, the vaccines and the misinformation that may exist in our current climate and culture around that, both provincial or both um, I guess provincially as well as politically, that also has an impact on how we can access that information. So I will stop there because we have quite an array of topics, but I will ask if anyone else in my group wanted to add something to that, if they think there was anything really key that I may have missed that we touched on. Okay.
That was great, Christy. Thank you so much. I know we're near the end, but are there any questions or comments or just insightful things that came out from what you discussed or what the PFD panel discussed?
I mean, what Christy said, I think there's a couple of things we talked about as well, kind of go along with what she was mentioning, because, and I'm trying to remember, we had a couple of things. One was, I guess, the University of Alberta, because Sean was saying, hey, we get this sort of proactive, memo that comes out or whatever, probably debated by a few people, and it goes out to all the transplant recipients and or immunocompromised people. So which is sort of pushing it out to because we're always trying to look for the stuff, or we don't think about it, but so getting it out into a patient's hands, I think, is useful. And so we're discuss a little bit, maybe with Treat COVID, that's the kind of mechanism we actually send periodic things out. And Charles suggested, hey, it could be little videos, 20-second videos. Hey, we found this out, and so just to sort of promote the dissemination of information, that was one thing. And then Christine said, yeah, there's some stuff like in Ontario, trying to get information. She was trying to get it from UHN, trying to get it out, disseminated as transplant ambassador to the bigger community. But it'd be easier if there was some place where that was sort of coordinated, maybe across Canada. So maybe we can use that sort of Treat COVID mechanism as a way to disseminate information a little more proactively to people that are dealing with a specific set of circumstances like we are. And so that there, and it's just when Christy was talking about it, so we did talk about a few of those things, and those are some ideas.
Excellent, thank you. Awesome. I am going to wrap up the session if there aren't any other questions. So definitely I just want to thank the speakers, Dr. Dima Kabani, as well as Rank Sherry and Lindsay Thompson. Thank you so much for being part of this presentation and giving us not only insight into what Treat COVID is doing, but just your day-to-day experience of being in the reality of what's going on. And please do enroll, sign up. I think MC has put in the bit.ly link a couple of times. They will take you right to the data platform and you're able to self-enroll at some sites. And if you have any more questions around the study, you can always contact the research coordinator that is associated with the transplant center you're part of. I'm going to hand it off to Manuel and say a big thank you.
And I'll hand it off to Lindsay. But agreed, thank you. As I said, last year we 17, 18 seems to be our magic number for the end of a PFD forum. So on my behalf, like thank you for staying around and contributing to the conversations. We need this, as I said from the beginning. This is information we need. We need to hear your perspectives, and there'll be follow-up based on this. But again, thank you. The brave souls, I said it last time. You are all brave souls. So with that, I will pass it off to Lindsay to close out today's PFD forum.
Okay, so that wraps up the final session of the day. I want to thank you all for attending the 6th annual PFD Research Forum. Before we wrap up, I also want to sincerely thank everyone who joined us today, from patients, families, and donor partners to researchers, clinicians, community leaders, and supporters. Your presence, your voices, and your commitment to improve the donation and transplant system makes this forum meaningful. Your priorities drive the work of the CDTRP. A special thank you to our speakers and panelists who shared their experience and insights so openly. And of course, a big thank you to our partners, including Astellas, for their support as friends of the forum, and to CARM, the Caribbean African Regenerative Medicine, for their partnership and contributions in today's discussions. Today's forum has highlighted the power and the importance of patient engagement in all aspects of healthcare, specifically in research, donation, and transplantation. We began with a session on co-creating tools for meaningful patient, family, and donor engagement, emphasizing practical strategies and inclusive research design. We then explored patient choices, health myths, and lived experiences during the Conversations About Health in Black Communities session. And the forum has just concluded with the Treat COVID National Prioritization session, where researchers and partners shared the insights into the ongoing impact of COVID-19 on the transplant community. Today, we've seen the strength of collaboration and action. We have heard from how research is made better when patient, family, and donor voices are embedded from the start, not just consulted, but truly integrated into the process. All three sessions have highlighted why we need everyone's voice, including researchers, trainees, and community in these conversations. You all have the role in contributing to research. You're the people with the lived experience. So again, thank you all for attending. I hope you all have a good rest of the day, and we'll see you next year.
You are the Canadian Donation and Transplantation Research Program. You are CDTRP.
The CDTRP is a network of more than 400 clinicians, senior, mid, and early career researchers, trainees, patient, family, and donor partners, and 100 partner organizations. Our network has supported 275 collaborative research projects and has mobilized research into policy change, legislation, commercial products, and improved knowledge for patients, families, and donors. Every year, CDTRP supports between $30 to $40 million in grant applications, something around 60 to 70 individual applications. You are CDTRP. These achievements wouldn't be possible without your hard work.
CDTRP Research Services is a platform that supports principal investigators to develop high-quality research in donation and transplantation. We work hand in hand with CDTRP investigators to maximize the effectiveness of research teams through support with funding development, project management, patient, family, and donor partnership, knowledge mobilization, events, and trainee support. Across the 5 research themes, we help teams mobilize new knowledge to ensure patient-family donors, healthcare systems, partners, and stakeholders equitably benefit from research results.
If you are a basic scientist and would like support with your knowledge mobilization plan, if you are a busy clinician scientist with limited time for research but would like to run a multi-site study, if you are an early career researcher and looking for collaborators to help with your grant applications, if you value patient, family, and donor engagement but are not sure how to find the right patient partners or what role they will have in your project, if you don't have full-time research staff but need support,
We are here to help. Our experienced management team can support you at every stage of your research in donation and transplantation.
Now you are probably thinking, how can I request CDTRP research services support? The answer is simple. Go to the CDTRP Research Services Platform website, fill out the form to request support, and we will get in touch with you to discuss your needs. That's it.
We.
Nous.
Noi.
Nos.
Emis.
Nosotros.
Menk.
Kia no. We. Kia no.
Our CDTRP, and we will drive research advances so that every wish to donate is fulfilled and transplantation becomes a lasting and sustainable cure.
You are CDTRP.
Email us today.